All right, welcome everyone. Today, we're really going to dive deep into a complex topic, hematological malignancies. Now, what are these? Well, they're the cancers that start right in the very core of our being, our blood and bone marrow.
And really, this whole explainer is going to circle back to one big central question. How does this incredibly intricate, life-sustaining system that creates our blood, how does it turn against itself? How does the very factory that builds our blood cells become the source of such a devastating disease?
So to get to the bottom of that, here's our game plan. We'll kick things off with the basics of normal blood production, hematopoiesis. Then we'll get into the pathogenesis. That's how it all goes wrong. After that, we'll look at classification, zero in on the leukemias, and finally, wrap up with how these diseases are actually diagnosed.
Okay, let's jump right into our introduction. So at their heart, hematological malignancies are simply cancers that start in our blood-forming tissues, like the bone marrow. But we're aiming for more than just a textbook definition today. We really want to get a deep, functional understanding of what's happening.
So by the time we're done here, you should feel comfortable explaining the pathogenesis of these diseases. You'll be able to use the WHO's classification system, outline how doctors diagnose them, and summarize the basics of clinical management. Those are our main goals for this session.
All right, next up, the foundation. We're talking about normal hematopoiesis, and this is so important because you really can't appreciate the chaos of cancer until you understand the incredible order of the healthy system. This is the process that creates every single blood cell in your body.
So where does all this magic happen? Well, in adults, it's pretty much all happening inside the red bone marrow. You'll find this active marrow in the spongy parts of our axial skeleton, so think your vertebrae, ribs, sternum, and pelvis. This is literally the engine room for our entire blood supply.
And check this out. The entire massive hierarchy of blood production starts from just one truly remarkable cell, the multipotential hematopoietic stem cell. It's the ultimate ancestor. From that single starting point, things split into two major pathways. You've got the common myeloid progenitor, which is going to give us our red cells, platelets, and granulocytes. And then you have the common lymphoid progenitor, which is the source of our T cells, B cells, and natural killer cells. The key thing here is that every single mature cell has this perfect, traceable family tree.
And here, this is what that clean, complex diagram looks like in the real world. This is a stained slice of active bone marrow. Just look at the sheer density of cells. It's like the factory floor is completely packed. You can even spot the big guys, the megakaryocytes, which make our platelets, right next to all these clusters of developing red cells and white cells. It's just a beautifully orchestrated and unbelievably busy place.
So we've got this beautiful, elegant system, right? Now what happens when it all gets disrupted? That brings us to pathogenesis. This is really the study of how that orderly production line can fall apart and descend into the chaos of cancer.
It all starts with a genetic mistake. When one of those hematopoietic stem cells, or one of its early descendants, picks up some critical mutations, that carefully regulated program for making new cells just breaks. That right there, that's the fundamental event. That's what kicks off a blood cancer.
Now this idea that it's all about genetics, that leads us perfectly into how we classify these diseases. With all this complexity, you've got to have a framework, right? And the global gold standard for this comes from the World Health Organization, or WHO. Their system is all based on which cell was the original one to go bad. This chart from the WHO gives you the whole picture. Now, don't feel like you have to memorize this whole thing. That's not the point. The really key takeaway is the core structure. Right at the top, you see that fundamental split that perfectly mirrors normal development. Myeloid on one side, lymphoid on the other. Pretty much everything else flows from that first big distinction.
So, to make that big chart a little simpler, let's just focus on those two major family lines. Cancers that come from the myeloid path include big ones like acute myeloid leukemia, AML, and chronic myeloid leukemia, CML. On the other side, from the lymphoid path, you get diseases like acute lymphoblastic leukemia, ALL, and chronic lymphocytic leukemia, CLL. Just knowing which of these two families a cancer belongs to, that's the absolute first critical step in figuring out what's going on and how to treat it.
Okay, so let's zoom in a bit on the leukemias, because they make up a huge chunk of these cancers. We've already talked about the myeloid versus lymphoid split. The next big question we have to ask is about the timeline. How fast and aggressive is the disease? And really, this is like a tale of two completely different diseases.
Acute leukemias are just explosive. They're all about a super fast takeover by these very immature, useless cells we call blasts. And without immediate, really aggressive treatment, these can be fatal in just a matter of weeks. Now, chronic leukemias are the opposite. They're much slower, more indolent is the term we use. They involve a gradual buildup of cells that look more mature, even though they're still not normal, and patients can often manage these diseases for many years.
This is such a great way to picture what's happening at the molecular level. For acute myeloid leukemia, or AML, we often talk about a two-hit model. So you get a class 1 mutation, and that gives the cell a survival advantage. It's like you're slamming your foot on the gas pedal. Then you get a cooperating class 2 mutation, and that messes up its ability to mature. It's like you've cut the brakes. And what's the result? You get a cell that divides like crazy and can never grow up to do its job.
Okay, now contrast that with something like chronic myeloid leukemia, or CML. CML is the textbook example of a cancer driven by one single, very specific genetic screw-up. What happens is, a piece of chromosome 9 and a piece of chromosome 22 swap places. This creates a brand new fusion gene called BCR-ABL. And this new gene makes a messed up protein that's basically a super powerful growth signal that's stuck in the on position, completely ignoring the body's normal controls and just driving the disease forward.
So all of this brings us to our final section. How do we take all this complex molecular knowledge and actually use it to make a diagnosis in the real world? This is the journey from a patient feeling sick to getting that definitive lab result.
The whole diagnostic process is really a logical sequence of steps. It usually starts with how the patient feels. They might come in with classic signs of bone marrow failure, like being really tired from anemia, getting a lot of infections because they don't have enough white cells, or bruising and bleeding easily from low platelets. That's the cue for a doctor to order a full blood count and look at a blood smear. And if they see weird cells, the next definitive step is a bone marrow biopsy. And that sample gets sent off for a whole bunch of advanced tests to figure out exactly what kind of cancer it is.
And when they look at that biopsy, one number is absolutely key: the blast count. The official rule, according to the WHO, is that if more than 20% of the cells in the bone marrow are these immature blast cells, that's the definition of acute leukemia. Hitting that specific 20% threshold is what locks in the diagnosis. And that kind of brings us to a final, forward-looking question to chew on. We've just seen how diseases like AML and CML are fundamentally defined by very specific genetic mistakes. So, as it becomes cheaper and more routine to sequence a patient's entire cancer genome, are we going to move past these broad categories like AML? Will we instead start defining each cancer by its own unique molecular fingerprint? It's a question that really gets to the heart of where precision medicine is headed in hematology. Thanks so much for joining me for this.